next topic. So now may I request Professor GC Khilnani, who is has been ex-HOD, Department of Pulmonary Medicine and Critical Care and Sleep Disorders at All India Institute of Medical Science, a great friend of mine. Sir has also been one of my mentors. I always look up to him. And now he is working nowadays in PSRI. And probably next half an hour or so, Professor Khilnani will be enlightening us about pneumonias and the challenges which we are facing. In fact, post-COVID, people have become far more now aware about the presence of respiratory medicine and its illnesses, and also the air pollution has been much more aware. And this year, if you can all agree with me, I hope that we are seeing actually the deluge of a lot of bacterial pneumonias. And this year, last year, like we had 2 years COVID pneumonia, now we are seeing this year a number of cases coming with influenza and also bacterial pneumonia. With these things, I think Professor Khilnani, all of you know very well, at least in pulmonary critical care and internal medicine, everybody knows about him. He has been teachers, and I now request Professor Khilnani sir to take over, start the proceedings and deliver his talk. Thank you.
Thank you, Dr. Dhruv. At the outset, it's amazing pleasure and privilege for me to be standing here where Dr. S.K. Sarin, my senior from my college times, and luminary in his own right, who is actually steering this program and gave me the privilege of being the first speakers of the session. I have great respect for him. Thank you, Dr. Sarin, for giving me this opportunity. It could be a little disadvantage talking after Sanjay Tyagi, who has given amazing disposition, and Dr. Umesh Kapil, who's been a senior colleague of mine, and other executives of NAMS. I'm sure.
Sir, kindly adjust the mic, sir. It is the voice is very, very low, sir.
नहीं वो ठीक है, मैं पीछे आप बंद कर लीजिए किसी और का, तो इको आ रहा है, वो ठीक हो जाए, कोई बात नहीं.
So thank you very much. So I'll start again. I guess I was not audible. Am I audible now?
सर डालो सर, एक्चुअली जब तक साउंड
सर आवाज आपका ऑडिबल है, थोड़ा सा गूंज रहा है, बाकी अदरवाइज इट्स फाइन.
ठीक है, ठीक है, ठीक है, आप प्लीज बोलिए, कोई साउंड की प्रॉब्लम नहीं.
So I'll start again. Thank you very much, Dr. S.K. Sarin, my teacher, my senior, and Dr. Umesh Kapil, and Dr. Dhruv and Chair, would be a little scary also. And I feel I'm under some kind of evaluation. So nevertheless, the topic I'm going to take is of patients with pneumonia. It's a huge topic. And pneumonia is not a domain of pulmonary medicine. Every physician, everybody has to deal with it. And we actually saw that in COVID.
ठीक है. ठीक है. नहीं ठीक है.
So, William Osler, 1901, said the most widespread and fatal of all acute diseases, pneumonia, is now that time there was no antibiotics. Pneumonia was considered the second cause of pneumonia. After sanitary cleanliness, it continues to be most common cause of infection-related mortality. Affects 4 million adults in the United States. The sixth leading cause of death. So many things have changed. Changing spectrum of etiology, whether you are not diagnosed, whether they are newly coming, and COVID, during COVID, we see everything. A lot of resistance has come in the community, having great difficulty in managing these patients. And there is an increased number of people who are immunosuppressed because of the age, because of chemotherapy, because of the several diseases, diabetes, and all this. So I divided my presentation among community part and hospital part. And I'll emphasize more on community acquired pneumonia, and for these, I'll be calling it as CAT. To start with, I present you two cases. This 21-year-old male resident of Delhi who presented with fever, cough, expectoration for 7 weeks. Another 21-year-old male of Indian origin from UK. He had a similar symptoms, and if you can see, he presented with the same symptoms and similar kind of thing. He came to me almost at a similar time while I was working in India. Both was managed according to guidelines. It started now antibiotics, former sugar, and provided. The one person improved, the other person worsened. So we did a CT scan for the person who came from UK. As you can see, he has got whereabouts and a little bit of sputum diffusion. And when we tested the sputum, this patient was therapy positive. Why I am showing is that pneumonia is not pneumonia is diverse, and it is exemplified during the COVID time. We saw during the pandemic, every respiratory symptom was considered to be only COVID and COVID. And we saw a variety of CT pictures, story. That is also pneumonia. That is also community acquired. So during the time allotted to me, I'll be giving you a clinical rather than the theory as to how do we manage the theory. Clinical approach to community acquired pneumonia. By no means I will be able to cover all the microorganisms or viruses or infections or pneumonia. But if I am able to emphasize as to how to approach, my job would be done. So there is a 73-year-old male who was never smoker, hypertensive and diabetic, came to the OPD with fever, cough, expectoration for last 5 days, shortness of breath for last 5 days, with few episodes of desaturation. His wife is a medical doctor who noticed that saturation was 89%, so she rushed her to the hospital that I am working now. He had blood pressure which was close to normal. He had SpO2 was 89%, which was recorded at home. He had left with the patient next day was almost normal. The abdomen was soft, the TLC count was high. So, does a normal X-ray rule out CAP? That was the question. And I remember my olden days when we used to ask for a CT scan 30 years back. They always used to frown upon us. Why you are asking CT? Why you are every time? You are investigation. So, this is a study which has been published. And we saw the value of CT scan. 18% of CAP may not be seen on this. So therefore, if the patient has, especially a susceptible person, an elderly, a diabetic or whatever, if he has fever, cough, chest pain, or with or without shortness of breath, stress hormones, there are critical signs of immune reputation don't help. Especially the left side, left lower nose pneumonia, especially posterior basal saline, and because of the heart disease. So this patient, when we did the CT, found he had a left lower lobe solicitation, not the classical which has bound to line, but pneumonia was very obvious. So this was the CT scan that we did as he came to us. Of course, there are some changes on the other side on the diagnosis. His PLC was 15,000, but we did sputum rather than was negative. Sputum culture was negative. The H1N1 test was negative. The true rapid was around 0 points. This is the background and my whole CAP based on this question. So how do you first I will talk about the microbiology and diagnosis and how to do the antibiotics and the duration of antibiotics, and that's all will be about. So you can do a sputum, gram cell culture, you can do a blood culture, urine antigen, two calcitonin, you can test for TB and you can do drops. The question is, does every patient require this kind of evaluation? So the sputum, and I will decide the three guidelines. One was the guidelines which were published by Medical College of Health Physician and Indian Health Society, we will hold this. Other guidelines were published by Indian Society of Physical Science and third guideline by IDSC guidelines. So I'll be citing this guideline to give my opinion on it. Sputum examination is important for achieving a diagnosis, but majority of guidelines say that it is not required for people who does not require hospital admission. Only people who are critically ill or require hospital admission, a good quality sputum is important, and sometimes a good microbiologist, or even on gram stain, would give you a good diagnosis. This particular patient, we did send a sputum, but the gram stain did not reveal anything. It was sent for culture also. So, the blood culture. Similarly, it has a very low sensitivity for diagnosis of pneumonia, but specificity is very high. The yield is something between 5 and 33% depending upon the severity. And one of the systemic reviews showed the true positive culture were 0 to 14%, and commonest organism grown were pneumococcus. And it doesn't change the antibiotic decision. The antibiotics have to be started within an hour of person coming. But who should undergo a blood culture examination? The IDSA has said intensive care unit admission, cavitary infiltrate, leukopenia, active alcohol abuse, severe liver disease, asplenia, positive pneumococcal urinary antigen, and person with complications like parapneumonic effusion should undergo a blood culture examination. There are certain tests which are antigen-based tests, urinary antigen test, serological test for IgM, for chlamydia and mycoplasma, and molecular diagnostic tests, which we have learned about more during the COVID times about this molecular biology. These are not widely available, more expensive. I have requested Dr. Dhruv to comment upon it at the end of this, because the time is very short. All these investigations should be reserved for the people who are seriously ill or hospitalized. You cannot afford to do all these tests for people who are in the outpatient setting. Now coming to the biomarkers. CRP was a biomarker which actually had no importance in management of community CAP. But this became important during the time of COVID, where quite a few of our decisions were based on CRP. But procalcitonin is one. Every ICU, every intensive care is using procalcitonin a lot. And these were the guidelines which Indian Society of Critical Care Medicine published. I was given the responsibility of steering that project. And I'll be reciting those guidelines because in my mind, the procalcitonin is overused. It's a very expensive investigation. So should PCT be done in hospitalized patients with CAP? That's a question. And does PCT help in discriminating between bacterial from viral and fungal antigen? That is extremely important. Sometimes our younger people take decision of saying that since the PCT is normal, they rule out bacterial infection and vice versa. Or if it is high, they say that it has to be we have to escalate antibiotics. So the baseline PCT level have not been consistently shown to reduce antibiotic exposure in CAP and lower respiratory tract infection. Most guidelines recommend against withholding antibiotics in lower CAP based on the baseline PCT. So the recommendation is that baseline PCT level alone should not be used to withhold empiric antibiotic therapy in patients with CAP. So PCT has no value in CAP. whether to decide whether it's a viral pneumonia or it is bacterial pneumonia, and therefore, what is the utility of PCT? Why it is done in so frequently? So, higher PCT levels are strongly associated with bacterial infection. The only utility of PCT is in de-escalation of antibiotics. So therefore, PCT should be done only in severe cases with CAP where you will be required to de-escalate antibiotics, and I'll come to it later. Now I talk about bronchoscopy. The pulmonologists, do it because they have it. If you call a pulmonologist to see a patient, especially in private sector, a respiratory case, he's ready with the bronchoscope. Immediately he'll say, I'll do a bronchoscopy. So I'll rationalize it. The impact of CAP on empirical therapy of diagnostic bronchoscopy, this was a small study of 88 hospitalized patients who has compared diagnostic yield of protected specimen brush and lavage in immunocompetent patients with CAP, followed by medication and initial therapy. The conventional sputum culture were also obtained, and PSB and BAL culture were added, 26 and 36% respectively. So therefore, it adds to that. Where should the bronchoscope should be used? Bronchoscope should be used if you have a doubt about the diagnosis, if your patient does not respond, if the patient has disease, is not producing sputum, and you strongly suspect that this patient be having fungal pneumonia, or the person might be having tuberculosis, or the person be having malignancy. Nobody comes written on his face that he has community-acquired pneumonia. But in the classical case of community-acquired pneumonia, where you have started empirical antibiotics, if he is responding in 48 hours of time, there is no wisdom in doing bronchoscopy. There is a lot of literature there on assessing the severity, because you have to decide whether to treat the patient, send the patient home with antibiotics, or you keep the patient in the hospital or put the patient in the ICU. There is something called PSI, Pneumonia Severity Index. I won't go into the detail. This is very complicated, this thing, but the simplest thing is curve 65 score, confusion, blood urea, respiratory rate, blood pressure, and age. These are considered for severity. But IDSA, given the criteria of major criteria and minor criteria, septic shock and need for vasopressor, respiratory failure, of course this patient will be in the ICU. Rest of the criteria are based on the clinical condition and the platelet count and so on and so forth. In the interest of time, so this case continued. 73 years old male who presented with fever for 5 days. He was started on antibiotics, cefiperazone, sulbactam, and moxifloxacin based on the clinical presentation and etiology. His age, diabetes. AFB microscopy was negative. Gene expert for MTB was negative. The gram stain pus cells were there, so the specimen was good, but it was negative. And we did his bronchoscopy after 2 days. So now come to what are the common organisms? And this will be the basis of talking about antibiotic therapy. The common organisms are Streptococcus pneumoniae, H. influenzae, Staphylococcus, Mycoplasma, Chlamydia, and influenza viruses. But whatever the situation may be, the Streptococcus pneumoniae remains number one bacteria all over the world, whether you are in the ICU, whether you are in the OPD or in the hospital admitted. But there are other organisms also, and this is a slide which is almost 10 years old. The coronavirus was always there, but this was not novel coronavirus. Coronavirus always caused respiratory outbreaks, but they were trivial. And it was always there as a cause of pneumonia. And nowadays, Dr. Dhruv will divulge on that influenza is the most common cause of pneumonia as on today. Tuberculosis. The Western literature does not say tuberculosis. Fungal, parasitic, and leptospira also, of which Dr. Dhruv is a champion. Now, this is a small MD thesis which was done in AIIMS in severe cases of CAP, where 8% patients were actually found to be tuberculosis. And all these patients had short illness. So what should be the initial choice of antibiotic? With the background of microbiology, with the background of radiology, and this is the guidelines which were published 2019 of Indian Society of Critical Care Medicine of antibiotic use in the ICU. So the initial treatment of outpatient with the CAP, the patient who does not require admission, that means he has come with fever, cough, and the X-ray showing small pneumonia, he is an immunocompetent person, young patient maybe. If there are no comorbidities and risk factors of there are no risk factors for MRSA or Pseudomonas, doxycycline or macrolide or amoxicillin is sufficient for the treatment of such cases. Or if the person has comorbidities, or if he is elderly, or if he has diabetes, or anything for that matter, then amoxicillin clavulanate or cephalosporin plus macrolide, which could be clarithromycin or azithromycin, or doxycycline, or it could also be a monotherapy with respiratory quinolone. And I'll tell you why we should not use respiratory fluoroquinolones like levofloxacin or moxifloxacin in our setting. The patients who are admitted in the hospital and who do not have risk factor for MRSA or Pseudomonas, and combination therapy with beta-lactam and macrolides, or monotherapy with fluoroquinolones is sufficient, or it could be a beta-lactam with doxycycline. The dictum is you have to give covering for atypical organism, that is Mycoplasma, Chlamydia, and Legionella, because these are not the one we are diagnosing by microbiologically, and these we know are the common causes of community-acquired pneumonia. Now, as far as ICU is concerned, if the patient is in the ICU, then you have to use antibiotics which are different. Patient with CAP requiring ICU admission should initially receive always a combination of an antimicrobial, that is 2A. That means there is a strong recommendation on this. The recommendation is non-pseudomonal beta-lactam. It could be cefotaxime or ceftriaxone or beta-lactam with beta-lactamase inhibitor plus a macrolide must be given. This is the usual. There is no wisdom in going overboard in a classical patient with community-acquired pneumonia. If you follow the guideline, or if the macrolides cannot be used, which can happen sometime, a fluoroquinolone may be used if no clinical suspicion of TB after sending sputum or endotracheal aspirate samples to rule out tuberculosis. There is an evidence scientifically, if you by mistake treat a patient of pneumonia with single antitubercular, that is fluoroquinolone, you are creating a resistance, you are increasing the mortality, and also you are delaying the diagnosis. Three harmful effects will occur. So therefore, there is no for that. Now, when to suspect anaerobic infection and Pseudomonas infection, that is important. The risk factors for anaerobic infection are dysphagia, altered sensorium, coma, witnessed aspiration, putrid, foul-smelling discharge, presence of lung abscess, empyema, or necrotizing pneumonia. These should be understood, and antibiotic will be altered. Similarly, risk factors for Pseudomonas infection, anybody who has structural lung disease, which could be bronchiectasis or interstitial lung disease and so on and so forth, somebody who has been on frequent steroids or prior antibiotic therapy, old age, immunocompromised state, or enteral tube feeding, or cerebrovascular accident, or advanced cardiovascular disease, or prior antibiotic therapy. All this will qualify for the person to receive anti-pseudomonal coverage if the patient is moderately or seriously ill. Now, finally, what we are saying is MRSA in community. I don't have time to show such cases. I have several. So when to suspect MRSA? So influenza is most important. Historically, if you go to the Spanish flu, more people died because of secondary infection rather than because of the influenza. And whenever the person has influenza, staph is a common secondary infection, of which MRSA is important. Prisoners, professional athlete, army recruits, drug abusers, regular sauna users. If there is a cavitation or necrotizing pneumonia, there is a solid evidence for staph, of which MRSA would be very important. I won't be loading you with antibiotics for these because this is beyond the scope of this book. Now, status of quinolones I have already briefed in India in linezolid, which is a very good antibiotic for staphylococcus, especially for lung, having very good penetration. For patients with severe CAP requiring ICU admission without risk factors for Pseudomonas, a combination of beta-lactam and macrolide should be used. Now, if you use quinolones, I've already said that you are creating resistance and also increasing the mortality. So back to our case, 73 years old male, who came to us, we treated it with civaparazone, sulbactam, moxifloxacin. We received sputum culture report, sensitivity report. And it is grew actually streptococcus pneumoniae. And it was sensitive to all the drugs, but it was resistant to levofloxacin and moxifloxacin. So we gave him azithromycin. So patient was continued on these antibiotics, and after 1 week, injectable antibiotics were stopped. He improved. After a total of 7 days, switched to cifodoxime clavulanate and was discharged home. His TLC came down, temperature came down like this, as you can see in this graph. And after 14 days, the CT showed complete clearance. And then he was a diabetic, elderly, and had several comorbidities. That's why this overuse of antibiotic, if you could say, was received. Is there a role of steroids? The final part. We have a very short fuse. When there is influenza, we don't give steroids. It's counterproductive. When there is COVID, you give steroids. There's a lot of confusion about it. Evidence is lacking, whether in a garden variety pneumonia, but if somebody has got septic shock, you give steroid. The steroid in critical care is a very big question, but the evidence is, this is a meta-analysis, there is a questionable benefit of steroids in severe CAP. So it should be individualized. If the people who are in severe sepsis and septic shock, you have to rule out the contraindication and realize that steroids are always double-edged swords. They cause hyperglycemia. There is more evidence of secondary infection. So this was about CAP. Dr. Dhruv, can I take 5 more minutes?
Yes, please, sir.
I'll just touch upon ventilator-associated pneumonia, which is actually closer to my heart, having done so many studies on that, so I can't do without talking about it, but I'll finish quickly. So definition of CAP I've already recited. HAP is, as we call it, pneumonia developing 48 hours or more after admission. The one who is not intubated at the time of admission. If the patient is intubated, then it is called ventilator-associated pneumonia, that is VAP. Now, it is important. The crude mortality of VAP is something like 71%. So if the person is on ventilator, he develops pneumonia, 2/3 life is already lost. This is little oldish data, but holds true even today. So many people, don't allow their next of kin to be ventilated. The ventilator says, "Kabhi nikalta nahi." But critical care has changed. Majority of data in hospital-acquired pneumonia come from ventilated patients because microbiology is easy to obtain. So this is a case 2. A 56-year-old gentleman diagnosed with COPD, admitted with COPD exacerbation. He had worsening respiratory failure, then had to be intubated, as you can see the endotracheal tube. I'll go quickly, but on third day, he developed fever with infiltrates on X-ray chest. His TLC was 18,300, and this is what is the definition of VAP. VAP, if it develops after 48 hours, fever, increasing pulmonary infiltrates, leukocytosis, increase in purulence or the quantum of secretion. This is the basic definition. Over the decades, it has not changed. So many things have come, but this is what basics is. So this patient has hospital-acquired pneumonia, that is VAP. That impact is that it increases the duration of mechanical ventilation, ICU and hospital stay. A small study that was conducted in AIMS, which clearly showed that it increased the mortality significantly, even being a small study. The clinical definition, as I said, remains same. The clinical suspicion, if there's increasing in the radiological shadows, if there's a fever, leukocytosis, and if there is all these features, we call it VAP. People have tried to come up with a CPIS score, which is where the tracheal secretions are also used, PF ratio is also used. But nowadays it is not being used. Initial sensitivity was about 80%, specificity was about 50%. But some people feel that it is good for de-escalation, but in practice it is not used. There is always a difficulty in differentiating it from other conditions like pneumothorax or the collapse of the lung, fluid overload, or ILD for that matter, ARDS. So, coming to the microbiological diagnosis. And that is very important to decide not only of the antibiotic for that particular patient, but it is important to know the flora of microbiological flora. We have been struggling with the ICU infections and antibiotic resistance. So tracheal aspirate, minibal, and bronchoscopy. These are the three. Majority of the data all over the world come from tracheal aspirate, and this was a small study done very long time back at AIMS, where we compared the tracheal aspirate with minibal, which was done with the two catheters, and bronchoscopy. All patients underwent all three procedures, and what we demonstrated that minibal done with the help of the catheter was as good. Wherever I work, when I was in AIMS and I am at another hospital, I insist that all my patients will suspected of VAP undergo a minibal with two catheter 8 and 16. You cut the catheter number 16 by 1.5 inch and do a tracheal aspirate kind of a thing, and it works as good as bronchoscopy. And we compared it with the international papers with bronchoscopy, and subsequently a study came, a Canadian study with more than 800 patients, which showed that bronchoscopy does not add to the diagnosis of VAP and does not change the outcome. However, the bronchoscopy should be done if you are suspecting things like malignancy or collapse or pulmonary alveolar hemorrhage, or the diagnosis in doubt, then you can do a bronchoscopy. So, the recommendation of IDSA 2016 says that for patients with suspected VAP or HEP, we suggest using clinical criteria alone rather than any kind of score or procalcitonin for that matter. Quickly coming to the treatment of VAP. I'll just take 3-4 minutes so that we have time for comments. It is certain that if the antibiotic therapy are adequate, the outcome will be better. And this is 3 of the 7 studies. These are the landmark study which showed that. And here again there comes the PCT. Whether it's used to decide antibiotic therapy, the answer is no. And the serial, however, the PCT have value in ICU when you are managing VAP and de-escalation of antibiotics. So serial PCT level measurement, preferably every 48 hours, should be used for antibiotic de-escalation. What are the common organisms? They would vary from country to country, place to place, hospital to ICU and ICU to ICU. And globally, aerobic gram-negative bacilli such as Acinetobacter, Klebsiella and Pseudomonas are the common. In India, GNBs somehow are the most common. And multi-drug resistant organisms are very common. Anybody who is elderly or on ventilation for more than 7 days with prior antibiotic use, which everybody is using, severe sepsis or septic shock, ARDS, renal replacement therapy, or systemic corticosteroid therapy should be considered to be having MDR pathogens. And what should be the initial antibiotic therapy? The initial antibiotics should always be a combination therapy. I'll have to quickly go through. The burning question is there a role of upfront colistin in therapy of VAP? This question was debated very vehemently and very hot debate was there because everybody is using colistin. So the recommendation was colistin is not recommended for routine use as empiric agent for VAP. However, it may be used upfront in the ICUs if there is high prevalence of carbapenem resistance to the tune of 20%. None of the ICUs that I know in India have a carbapenem resistance of less than 20%. So we all are concerned to use colistin, but these recommendations were not for the big cities or metro cities. These recommendations were for all over the country. So this is what the report that we get. Klebsiella resistant to all, only colistin and tigecycline sensitive. And we are actually plagued with these organisms. So what should be the optimal duration of treatment for VAP? I have seen in my practice in the All India Institute and also now, once antibiotics started are never stopped, whether patient responding or not responding. I had the privilege of going to all the ICUs in the All India Institute where senior resident was the boss. And he would, if he is fond of meropenem, he'll use meropenem for 4 weeks, 6 weeks, 8 weeks at the time the patient is there. But there is evidence. The short duration of antibiotic therapy should be used, that is 1A. That means solid evidence and strong recommendation. However, longer duration of antibiotics should be considered in VAP if there is a gram-negative bacilli, NF gram-negative bacilli associated with severe immunodeficiency, structural lung disease, COPD, bronchiectasis, empyema, lung abscess, necrotic pneumonia, or inappropriate initial therapy. This was a weak evidence, but strong evidence. So therefore, de-escalation of antibiotics is a very big issue in ICU, which should always be considered. In that, biomarker procalcitonin is helpful. That is the only use of procalcitonin in VAP therapy. I think I should finish quickly. There is a role of aerosolized antibiotics, especially colistin. Now, Astronam is also coming. Amikacin is also likely to be available. Tobramycin is available. But what one should understand that they should never be given in isolation. The aerosolized antibiotics must always be given with the systemic administration of the same antibiotics. There is very poor evidence that they do something, but you have to save the patient, so we use it. There is, as you can see from this analysis, there is evidence that nebulized antibiotics improve the outcome. So, IDSA says weak recommendation, very low quality evidence for aerosolized antibiotics. Final slide of prevention of VAP. We have been struggling. I struggled in AIMS. I am struggling at my hospital. The hand hygiene is extremely poor. Gloves and gown compliance. Gloves have very little role. Elevation of head of bed, oral care with chlorhexidine, maintaining cuff pressure, orogastric rather. Some of them are followed, some of them are not followed, but hand hygiene remains the most important part of prevention. And I would like to acknowledge the contribution of so many people who helped me and assisted me and guided me in conducting these studies. So sorry for taking a little longer time, but thank you very much for your.
Thank you, Professor Khilnani, for giving a detailed view of both. They are big topics in themselves, community-acquired pneumonia and pneumonia VAP. But nevertheless, sir, can you, because it's ricocheting, if we can switch off the microphone of one of those there. Now you said, because you have also raised, there certain important questions have been raised actually in this context. And most important part for us is, when we talk in terms of pneumonia, if you permit me to summarize it, epidemiological changes we are seeing a lot. Because of the better diagnostic facilities, earlier we used to think it's all bacterial, but we are realizing now that it is viruses or also other atypical organisms which we were not seeing it. Why I'm saying so is that during last 3 months or so, we have collected around about 45 cases where we did film array, multiplex PCR testing and all. No single thing has come up where we find only one organism. By and large, viruses have been influenza. We saw metapneumoviruses. We also saw in adults RSV. We also saw in these adenoviruses and also non-COVID coronavirus. All could have been detected. But along with it, we have seen H influenza, streptoneumoniae. We have also seen, Klebsiella and so on and so forth. So looking at it today, where influenza, the role which we are finding it up, in particular of a film array or multiplex PCR has been, when patients are coming up, they are a little sicker. We are not doing it, or as a part of epidemiological study to know what sort of infections are there. So what we were pleasantly found was that our upfront use of antivirals against influenza went up this season, and antibiotic use has declined by nearly 1/4. Because whatever the URC we are taking up, it was all H3N2, and then later on when they got into influenza, we saw both influenza A and B. So the point I'm saying is that simply looking at bacterial pneumonia, we might be missing a significant patients actually having a viruses. So that is one part which I want to make emphasis is. But yes, they are not readily available, they are expensive. But by and large, other multiplex PCR tests have started coming up available. One. Second, sir, you have talked in terms of diagnostic, because one of the big challenges is, if I do blood culture, will it alter the course or not? Because that's one. So people have been trying to use quite often the combination therapy like you have recommended it, beta-lactam inhibitors plus macrolide. So that takes care of most of the organisms as far as the bacteria is concerned. So that is also the second reason because of which people don't go for very extensive testing. And if you see, it's even if you look at ICS NCCP guidelines and even our guidelines from ICCM, we are seeing those patients who are hospitalized in the ICU are the ones where we need to do blood cultures. Otherwise, there is no need for it. But by and large, it is the syndromic approach which is taking over now, the diagnostics of community-acquired pneumonia. Sir, another thing which you have raised is, which I hope people should not take the other way around, is X-ray still continues to be first line of investigation most of the time. A role of sonography has come up, we evaluated it, and when we compared it to the CT as a gold standard, practically more than 90% cases have been picked up. Most of the problem is those areas left lower lobe or other areas where you don't do it. But if you repeat XCXR in 48 hours, then they pick up. Yes, sensitivity part is one. And another, sir, which I think which is very important, which you also made up, is a switch therapy from oral, injectable to oral. Because otherwise it continues. And the guidelines are very clear that if you continue to be afebrile for 48 hours, counts are going down, improving, it is better to switch over to oral therapy at the beginning. And one particular condition, sir, I'm very fond of, I hope my colleagues will agree, is a mellidosis. It is underdiagnosed. It is commonly seen in South India. Dr. Ashok Kumar Das sir is there. So it's in Pondicherry, because they may be coming up with it. So golden rule is any septicemic, sick patient of pneumonia coming up with the hypotension, shock, diabetes or chronic alcoholics, which are there, we must consider it in a differential diagnosis, especially if you are finding an upper lobe pneumonia with a cavitation. It must come in differential diagnosis. And if you have got a skin lesion along with it, a person is coming from the rural background, mellidosis must be considered upfront, because otherwise mortality can be very high in these patients, and the drug of choice immediately shift over to ceftazidime. That's how sometimes the clinical clues come up, and if you're finding along with seizures or neurological symptoms, besides other things, mellidosis is one which is there, and probably the swabs, we have all forgotten the technique of doing gram stain, sending it up and getting upfront. I think we need to emphasize. From there we pick up before even the cultures can come up. And I would like to have the comments of my distinguished colleagues here also. Procalcitonin, sir, you have already pointed out. VAP, sir, I want to make some couple of comments because that area is also a topic we have discussed so many times, and then I will open it up. There is no distinction between early VAP and late VAP now. We used to talk of early VAP in more 48 hours to 7 days, and now after 7 days, you will agree with me. Practically, it is all CRE we are seeing. Sir, we did a study at Rohtak when the patient was admitted into the intensive care unit, and we took an anal swab on day 1, day 3, and day 7. Day 1, we were shocked. Out of 90 cases, 39 were having CRE. The day 1 of ICU admission. We are sitting on so the AMR becomes a very important component for us, and therefore it also alters the change of antibiotics, and by the end of 1 week, practically everybody had a CRE in it. So that is what is a very scary situation which we are getting from outside, and with inter-hospital transfers of patients, that is becoming a very, very big part of it, sir. And also, diagnostics, ultrasound again has come up a very big way in picking it up early. And as you have very rightly said, I'm re-emphasizing it. Any worsening hypoxemia, increased purulence, and along with it, if you see a new signs, or you may do a sonography which is on the bedside, can actually pick up with the very great sensitivity the VAP in these cases. But nevertheless, it should be considered, and as far as the aerosolized antibiotics is concerned, and you had looked after it in the nebulization guidelines also of the combined NCCP ICS, you were looking after that section as a section editor. So what we have realized is tobramycin, I would just like to make a comment, because it has got an excellent penetration into the serum. Cholesterol, yes, will not cross the blood-brain. Therefore, if we are using tobramycin, we must not use any additional aminoglycoside with it. But yes, with cholesterol, we can combine it up. These were the few comments with this. Now I open it for the discussion, and we have few questions, sir, in the chat box. Somebody has asked you, sir, please comment on atypical mycobacterial infection and latent TB, but I think this is not the topic. And but in any case, I would like to have a comment from you, sir.
No, actually, I'll need 1 more hour to discuss that part. So, latent tuberculosis has nothing to do with community-acquired pneumonia or hospital-acquired pneumonia. And atypical mycobacteria, only thing is that a brief comment which is general is that with the advances in the diagnostic facilities with the gene expert, and also bactec culture facility, and also line probe assay and all those things, we are more and more diagnosing atypical mycobacteria and treating them. It has nothing to do with community-acquired pneumonia, to best of my mind. And managing them could be a challenge. At the present time, I am treating some of them, and this is very rewarding that we have diagnostic facilities. And I would say that whenever you have a patient with atypical mycobacteria, it should be treated by a person who has sufficient experience and knowledge of that. It should not be treated by the usual person. It should not be taken as my arrogance. Even I refer sometimes cases to the TB center to Dr. Singla for his expert opinion. So, but whosoever asked, thank you very much for being vigilant about it and wanting to be knowledgeable. But I'll be most willing to communicate with them on email or whatever if he has any question. But answering that question at this stage is difficult.
Somebody has written role of WGS. I still want, I'm not very clear what WGS in cap. I could make it out because it's an abbreviation. The only, I think, go up is a role of gram staining if I extend it up in the diagnosis of community-acquired pneumonia.
I don't know. In fact, I also saw that, but I can't.
I can't decipher it. What WGS is there, but nevertheless, Dr. Das, sir, any experiences with mellidosis in Pondicherry? Sir, please unmute yourself.
I think I'm speaking on the. Am I audible now?
Yes, sir.
Yeah. So I must tell you, Dr. Khilnani, it was excellent. Very brief. We are very close friends, sir. Now, Dr. Khilnani, I would just tell you that melioidosis is very common in the southern part of this country. It comes from the soil and water, to make a long story short. And we lose 50% of cases of melioidosis if we do not diagnose it early from the simple gram stain and septicemia-like structure that you rightly pointed out, sir. And you do not start the proper antibiotic in the beginning. The commonest presentation has been fever with multi-system involvement, and as Professor Chaudhary pointed, Professor Chaudhary, hats off to you. I mean, the seizure and the multi-system involvement is the hallmark of melioidosis and a high index of suspicion. So that's it. I'll tell you in big short. And recently, in one of the re-emerging infection international seminar, I spoke about melioidosis, and it was greatly appreciated, and I will highlight it some other time. I have a simple question to ask GC. GC, what's your opinion about the levofloxacin as an outpatient treatment? Am I audible, GC?
Come again, sir, with your question.
I was just asking about a very simple question from the undergraduates. What is the role of levofloxacin as an OPD management of outdoor CAP?
Sir, levofloxacin, moxifloxacin, and what is called respiratory fluoroquinolone have an amazing spectrum. And it reminds me of year 2000 when I was doing fellowship in critical care in Mount Sinai with the severest form of pneumonia in the ICU. They were treating it with levofloxacin, which was named as Levoquin. Single antibiotic was sufficient. But what has happened over a period of time, the cost of levofloxacin tablet is 7 rupees or 8 rupees or whatever. It has been so much abused and overused that it has lost its value. That is one. Second is that quite a few of these pneumonia will ultimately turn out to be, actually they are tuberculosis, and then we are treating it on OPD basis. And studying this subject, I realized that when you treat a tuberculosis patient considering CAP with levofloxacin or moxifloxacin or whatever quinolones you are using, you are delaying the diagnosis by 17 days, increasing the quinolone resistance, also increasing the mortality. Subsequently, the diagnosis will be delayed, and currently the quinolone resistance as far as tuberculosis is concerned is more than 40%. So if I combine them all, for India there is big no for using quinolones as an empirical therapy on the outpatient basis, because azithromycin, clarithromycin, doxycycline are amazing drugs with equal efficacy. So that's
why. Sorry for interrupting, sir. Now I have got a signal that time is coming up, so we need to cut down the discussion here. I hope you will not mind it. It's going to be 7 o'clock now. And I do agree with you, sir. We are using a lot of doxycycline in the OPD. And trust me, it has been an excellent drug. It is being underused, not being used, and practically takes care of most of the things. Whole genomic sequencing, said that was there. The answer to that question, ma'am, is whosoever has put into it is still experimental because there is a lot of background noise. But when you have detected, obviously you can do studies and can pick up the molecular diagnostic basis of resistance and all. With these remarks, thank you so much, Professor Khilnani, and my apologies to all my colleagues for cutting it abruptly a little bit, because in the interest of the time, it has to be done. Thank you very much, and I give it back to Preeti there for final conclusion of the session today. Thank you so much. And thanks, Dr. Serena and Dr. Sood and Dr. Kapil, for giving me an opportunity to chair the session. It has been an experience. Thank you so much.
Thank you.